All right, ladies and gentlemen, thank you very much. And we do apologize for that slight technical difficulty. So that, since working from home and doing digital things, I'm sure we are not, aware of all these technical difficulties that hinders us sometimes. Thank you very much. Very good morning, everyone. This is Siti Aziz, and I'm representing the Malaysian Red Crescent Society. It's a lovely Saturday morning. How are you guys doing? I hope everyone and just keeping safe at home and sanitize wherever you are. Okay, so today we have a webinar called, a very much anticipated webinar called the End the Silence on Domestic Violence. And we are very, very delighted to have roundabout, let me see, currently we have 185 and climbing participants. Wow, that is a very comforting figure, given the year and the year end and also, the stigma attached to this topic. So very delighted to have a lot of people on board. So for those who knows a little bit about the Red Crescent Society, or for people like me who, just remember being part of this society when you were in high school. So the Malaysian Red Crescent Society, or MRCS in short, is a non-profit organization dedicated to humanitarian acts and services. So we've been in Malaysia for about more than 70 years, and we have an army of volunteers, about more than 20,000 volunteers, and we are always actively looking for more people willing to contribute, with the aim to help Malaysians impartial to nationality, race, gender, religious beliefs, or opinions, which includes political opinions. So it is a part of global network to the International Red Cross and Red Crescent Global Movement, whose mission is to alleviate human sufferings and also to promote lasting peace amongst people. So a very noble mission. And ladies and gentlemen, by participating today, you are indeed in one way or another contributing to this goal. So thank you again for joining us today. So the Red Crescent also believes very strongly in PGI. So what is this jargon you're asking? So now that you ask, it stands for Protection, Gender, Inclusion. In fact, PGI is one of the main focus areas, which brings us to our topic today. And recent works on PGI includes the minimum standards for protection, gender, and inclusion in emergencies guideline, a hefty yet very comprehensive guideline. I've gone through it yesterday. So mostly it aims to ensure that the emergency programming of the International Federation Red Cross and Red Crescent Societies, and also the national societies, provides dignity, access, participation, and safety for all people affected by disasters and crises. Now, in Malaysia, we are blessed to have probably only watched real crisis in the television before. But now the topic is very relevant to all of us, facing this global pandemic. So do check it out. We will provide a link where you can access it. And it provides a practical guidance on how to ensure that these four principles, dignity, access, participation, and safety, based on the consideration of gender, age, disability, and other diversity factors, are applied. This includes limiting people's exposure to the risks of violence and abuse, and ensuring that the emergency programs do not harm. Okay, back to the topic today, domestic violence. Maybe just a short definition. I'm pretty sure the speakers will touch more on this and will elaborate further. Based on this definition I found on Women's Aid Organization Malaysia, domestic violence is a pattern of violence, abuse, or intimidation used to control or maintain power over a partner who is or has been in an intimate relationship. Fundamentally, domestic violence is about power and control. There are various forms of domestic violence, including physical, emotional, psychological, sexual, social, and financial abuse. Abusers often use more than one form of abuse to invoke fear or coerce a partner into behaving in ways they don't want to. So if you see from this definition, it is indeed very inclusive, very broad, and of course, it's not just limited to violence against women as mostly stigmatized. So here with us today, we have two very reputable speakers, and we are indeed very lucky. given their very, very hectic schedule. Thank you so much for being here. We have first Dr. Muhammad Alwi Abdul Rahman. He is the emergency and trauma specialist from Selayang Hospital, and he will be touching on the impact of gender violence on survivors and family. And secondly, we have Dr. Umi Azlin Silim, a consultant psychiatrist in Kuala Lumpur Hospital. So she will be touching on psychological first aid and mental health care. And the two of them combined, that's like more than half a decade worth of experience in this field. So thank you so much, ladies. Dr. Alwi and Dr. Umi for joining us. Thank you.
Hello.
Right. So let's get to it. Dr. Alwi, we're going to start with your good self. So gentlemen first, if Dr. Umi doesn't mind.
Wow.
For a 30 minutes, yes, for a 30 minutes time slot that we have following, we will be followed by the second topic afterwards. So meanwhile, ladies and gentlemen, I just like to remind that, while the speaker is speaking, do mute your mic and turn off your video to disrupt any to avoid any disruptions and embarrassing mistakes. So please do that for us. But however, do feel free to write your thoughts or questions in the chat box, or simply just raise your hand and speak to the camera or with your video if you are camera ready. So let's be open and candid. So we assure you that there is psychological safety here in the MRCS webinar, and we'd love to listen from you. So if you're okay, and again, it is very, very safe to speak up right here, okay? Now, it has been, almost 1 year, Dr. Alwi, that we are, living in this COVID era, living within the SOP, and a lot of things have changed. And like it or not, many people were facing a lot of stress with this change, as well as people, sometimes pushed to the brink of, if I may say, sanity even, and people losing their job or being in isolation, not with their family members during this time of crisis. And, a recent report issued by Bukit Aman Police that I read out on the internet, it says it doesn't necessarily point, the MCO doesn't point to a rise in domestic violence. However, we do hear stories of violence, like the recent viral one that very, very recently happened, that a guy actually, assaulted a woman in a parking lot for honking at him. So, although this is not in particular a domestic violence, it does leads up to the question of, violence and abuse. So what do you think? This alludes to this topic. So what do you think of this recent news, Dr. Alwi? Take it away.
Thank you, Puan Siti. So actually, let me say that this can you see the slides? Can you see the slides?
Not yet.
Slides? Yeah. No? Or let me go back again. Okay. Now, okay.
Yes, we can see it now.
Okay. Thank you, Puan Siti. Thank you to all the audience attending today's morning. Assalamualaikum, good morning. Well, once the domestic violence, the champion is always a woman, and we have seen in the past that a lot of NGOs, particularly the Awam and WAO, and there's a lot of sisters in Islam and etc. And there's a lot of, including the Ministry of Women and Child and Welfare Affairs. They are the champions. And of course, along the line comes the hospitals, a majority of the hospitals. And of course, the most important thing is the role that we all can play as a civilian, as a society, how to respond, how to prevent, how to understand, and to stop with to understand the issues of violence. I like to thank the IFRC for the opportunity given, and as well as the my colleagues and comrades at the Bulan Sabit Merah Malaysia, Malaysian Red Crescent Society, and of course the One-Stop Crisis Center Malaysia under the Ministry of Health, for which we have started in the 90s as a pioneer at Hospital Kuala Lumpur. And this has really contributed towards not preventing but reducing, because I don't think you can prevent violence against women, or intimate partner violence, or gender-based violence, or anything related to violence against family, as well as the woman per se. Well, there are about 1.6 million people all over the world, that exposed to violence, and mostly these are all about young people in age group about 15 to 44, and of course the violent victims when it comes to gender-based violence will be women and children, and of course the majority who die, of course, at the who started or the perpetrator will be men, and there are many types, many shapes of violence that which cause a lot of causes of premature death, as well as preventable deaths, and it is a public health issue in our country, and of course globally, and it is the responsibility of each one of us in every organization that is involved, including the NGO. I must thank the NGOs that without them, we could not achieve the objective of preventing violence against women and children. At the same time, they have really helped in supporting the emergency department per se in handling the violence. And they also are the link based on their cooperation and collaborations with the Police Raja Malaysia, and of course the Jabatan Kebajikan, the Welfare Ministry, and as well as the NGO and all the other NGO, both national and international, and of course the stakeholders, and they all are part of society's contribution towards preventing and as well as supporting the victims or the affected communities. As you well explained just now, domestic violence, the violence, it is perpetrated by, of course, the husband or the boyfriend or the someone who knows to them. And the violence can come from any amount, including physical, sexual, emotion, economic, psychological action, and etc. And violence comes even currently in the current trend of the current time is the woman trafficking. A lot of abuse of drugs, etc. So all this has contributed towards the greater impact of the violence, domestic violence in our society, and more so now, COVID, we spend more time in the house along with our family, with unemployment, with medical problems from the perpetrator or vice versa. I just imagine if you have to, if you are having acute kidney failure, you are at home and then you have to do 3 times a week of hemodialysis, and the husband has to take you, or you have elderly parents that you have to take care, and you are unemployed, you're fall into the poor background, and no education, and this violence is going to perpetuate and is going to grow, and COVID is adding more towards it now. All right, and we know the cycle of domestic violence. This is a very old slides that we start. I must say, the champion of this one-stop crisis center in Malaysia, particularly, was started by HKL, the emergency department. They always ask why the emergency department, and you must know the only department that opens 24 hours is the emergency department. And violence against women, violence against children, it happens 24 hours, and mostly when you are, coming back from work, mostly you're spending more time in the house, and etc. And I bet Dr. Umi can explain in detail the impact of when more of time spent in the house, the psychosocial impact. Right, the perpetrator, of course, as I said earlier, it is always the man, either a normal, abnormal man. Even it is very common about the blue collar working group, and they can use any amount of intimidation, emotional abuse, isolation, blaming culture. They can use children as a shield or as a cause. And now you can see that the last few years, the people are start while they are under the influence of drug, they throw their babies and neonates or children right from the roof of their house, and etc. because they have lost the sense of reality. When you are under the influence of alcohol, drugs, or any kind of drugs that can alter your behavior, you can do a lot of things that is beyond our imagination. And of course, the economic abuse currently, unemployment, deprivation, and cutting your 30 or 50% of your salary, all that is going to contribute towards the to the greater number of violence among the family members. And it is still the tip of the icebergs. And I must say that what we know is what we know. If the victim comes to our hospital at the emergency department and willing and voluntarily willing to share their experience, which is they do not reveal that they have been a victim of violence, because they just don't want to be stigmatized, they don't want to be known, and they rely on their husbands or the breadwinner to sustain their family or their children. That's the other things. So normally the doctors at the emergency department has to be trained to identify that the kind of violence suffered by the woman, either physical, emotional, or psychological. So it's only a tip of iceberg that we see, and certain kind of injuries it is hidden. So it's very difficult for us to identify at the emergency department what kind of injuries they present, unless this, if you have bruises, then it's very easy to see, and some of these perpetrators, they are well trained, so much so that they harm a woman or child in a hidden area, and which is very difficult for us to see. So these are the things that the doctors at the emergency department have to do. So it's only, as I said earlier, it's only a tip of the iceberg. And of course, as I say again, you can heal the wound, but you can't heal the emotion part of it, and that certainly it will reflect back to the long term of recovery and needs early acute intervention, particularly about the psychosocial support, etc. There's a lot of supports that a woman need when they come to emergency department, which is why the one-stop crisis center that we have developed in Malaysia to support the needs of the woman and child and those who are being marginalized in this. Whether
Yeah, Dr. Alvi, thank you. That's very interesting so far. Just wanna to highlight a question from Mr. Connie Tan. Would you like to speak up that question? Are you online? He has a very good question.
okay.
Mr. Connie Tan Lee Chu, are you online? Okay, seems like we have a shy one. I will read out his question. So, can elderly abuse be termed as domestic violence?
Yes, any amount of, it's a good question. Excellent, fantastic. As I say again, elderly, yeah, even you're sick or you are geriatric age group, they all, don't worry, one day we will go into that kind of group also. We all and they all are vulnerable, and that is considered domestic violence too. It can be also, even if you are in extreme age, and violent between even partners as well as their boyfriends. So, and those who are staying in the old folks home also can be treated as violence. So we have to see, and of course, it always start if they are reported to a police, then we can identify and can be categorized according to uh, the types of injuries and types of emotion that is involved. And of course, it covers everyone, elderly abuse, young, neonates, infant, etc. Maybe perhaps Umi wants to share something. Dr. Umi, do you have
Hi.
any idea on that?
I think, yeah, domestic violence can occur to any member of the family, child, elderly, spouses. And intimate partner violence will refer to spouses, husband and wife, or even now partners living together, or ex-husband, ex-wife, the intimate relationship. So it
Thank you.
covers everyone.
Thank you. Can I continue, Dr. Siti? Puan Siti?
Yes, sure.
Okay.
Please. Thank
Well,
you.
of course, according to the United Nations Entity for Gender Equality and Empowerment of Women, 2012, some risk factors include witnessing or experiencing abuse as a child, substance abuse, limited economic opportunities, conflict, tension within intimate partner relationship, male control over decision making and assets, societal acceptance of male domination and female subordination, lack of safe space for women, normalization of violence in the media and within the home, and the lack of punishment for perpetrators of violence against women. So, can you just imagine if you have 8 members in a family, but there's only 2 rooms or 1 room, and you got one big hall? How are they going to live? And the space is not sufficient. And look at their day-to-day activities, even sharing their food, sharing their amenities, sharing all the other basic needs of human. So these are the things that we need to look into it when we are going forward towards the future plan in our infrastructure as well as our life. And of course, according to WHO, these slides are very common slides that are being used by the OACC group presentations by my teams, HKL, and all over Malaysia. And it is a common thing that we reflect sharing WHO's experience globally, particularly the intimate partner violence, which is also domestic violence that is involved in terms of mental health care, sexual and reproductive health, death and injury. And of course, when mental health care, Dr. Umi will explain in very detail. And of course, the sexual reproductive health, we are talking about a woman in pregnancy, even they are highly vulnerable for violence. They have to go through 9 months and a lot of follow-up in the clinics and the hospitals and everything. And they not, during their visit to hospital, they may not, if they're undergoing a domestic violence or partner abuse, they may not reveal. So it is a job of the doctor that particularly handling these pregnant women, and they have to be alert and vigilant and looking at this any sign of symptoms of sexual abuse, any form of abuse. And of course, they are also vulnerability for mortality and morbidity. And sometimes they even a lot of mothers, if we could not intervene as early as possible and prevent the further deteriorations of this violence among the family members. And of course, the healthcare response is a global holistic response, and we have to look at how we want to manage the need of the woman, and then identifications and the care for survivors of intimate partners violence. The immediate clinical care, let it be at the emergency care, let it be at the role of the forensic, role of the ONG, or the psychosocial support from the psychiatry department, both short-term and long-term. And of course, training both the community, training the NGOs and doctors to train to identify the kind of injuries they sustain and to appropriately use the standard operating procedures that are set by the Ministry of Health to help them to get proper care and support. And we also look at the reporting, and reporting has to be done both at the hospital level. We have auditing how to report and what are the cases, and we share with this information with the police. And of course, police report has to be made, but it's volunteer. In domestic violence, reporting to police is a volunteer. If the victims, the survivor, or the family members, they want to report as particularly adult, they can. And if it is involving children, children under the age of 16, then it's a mandatory. The doctors will do the reporting under the Child Protection Act. And of course, the intervention will be how we looking at the treatment. Confidentiality is very important when they come to a hospital, or if we are dealing with the counseling, etc. And referral systems, the need for the woman, particularly not only the psychosocial support, we have to look at the clinical context in terms of ONG, in terms of obstetric gynecology, in terms of other even plastic surgery need because of the old scars and etc. And these are the things that we have to look into for the support of the survivors. And I said earlier, One Stop Crisis Center, it is designed in 1994, as early as possible, and it was developed at the Hospital Kuala Lumpur, which I was among the pioneer group along with the hospital, which is led by Dato' Sri Abu Hassan and Dato' Zahari is a forensic expert, and psychosocial, and of course the SCAN team, suspected child abuse and neglect team expert, I think Dr. Elaine, and there are a lot of psychosocial psychiatrics was involved as early as 94 in identifying the center. The center is an integrated, comprehensive, holistic center whereby any victims, let it be a dog, domestic violence, battered woman, or children that comes to emergency department 24 hours, they will be directly triaged to a dedicated room where the infrastructure and facilities will support them. They can come on their own or will be brought by police. And taking at the global statistic of domestic violence, there's a lot of about 33% increase in the helpline calls for domestic violence. You can see other countries. So this phenomena is very global, and you can't run away. And if you take from this Royal Malaysian Police information, the current trend is of course increasing, as you can see. Even in 2016, the maximum numbers are there, almost reaching to about 6,000 people. So the moral of the story is, we are in a real urbanizations. We are moving towards a fast development phase countries. There's a lot of challenges in terms of economic, social, politics, as well as health requirement. And there is a lot of people looking. There is a lot of migrations, including the refugees that we have in this part of the world, that is being subject to violence because of the way they live, the way their culture and their exposure, and of course the uncertainties in their future. So both Malaysians and the foreigners that is involved, they are vulnerable for violence, and is all recorded through the police, and subsequently they all will be brought to a hospital that we need support. As I said earlier, violence very common among the young people, and again the perpetrators, you can see by this police report, is always the young people. They are dynamic, they are challenging, they have a lot of challenges, a job, education, and they have shelter, and they have a lot of responsibilities, pressure, personal abuse and drugs and crimes and etc. and all that contribute. They all have do not have, most of them do not have access to counseling, do not want counseling. In fact, I can say not the access is always there, but do not need, or maybe they are influenced by certain group. And these are the issues. The young people, the youth crime is very common. So you have to look at these are the target group, high risk group that we have to focus. And of course, you can't run away from Klang Valley as being the highest number of domestic violence or battered. There's a lot of battered men there, and of course, the battered woman is more than a battered man. And violence against domestic violence even includes men also. So when I did a study in 2001. There's one man out of 256 cases. So there's one man being battered by the wife also. So equally, men also are vulnerable. Yeah. And of course, in this case, the woman is always the priorities, because they are the homemaker, and they are the one who going to make sure how our country is going to run and how our country is going to progress. And of course, the need of social worker is very important. As you can see, the social workers in Malaysia are doing excellent job, and we have referred a lot of cases to them. They are given not only about the domestic violence victims, those who don't have shelter, those who need food, those who need money to go home from hospitals to their home. And bear in mind that social worker work very closely with the other NGOs and etc. And NGOs are themselves, they have a lot of volunteer social workers which very closely work effectively, and they're very dynamic. I must say that without them, it's impossible for the Ministry of Health to do the job that we're doing now. And in these studies that is done by prevalence of intimate partner violence in Malaysia by Hayati Kadi, Shaha, Farida, etc., we have to look about the purpose of this review. Prevalence of intimate partner violence, domestic violence, and associated factors. As I said earlier about the youth, it is always the significant factors are the low education among perpetrators, background, economic status, substance abuse, especially prior abuse, violence, and of course, lack of social support. And we should focus on this group that, and find an intervention, okay? And then we need them to be referred so that they can do no further harm, which is what's the concept about the Ministry of Health or the health itself. Okay, and Siti was saying rightly so during the movement control order. Since March, March, middle of March, there's a lot of increase in case. As I say, Selangor is one that is championing the issues of violence, because this is where the hub of all economic, social, and political activities are happening. A lot of people are retrenched, support service are less, and of course, the government came up with a lot of efforts to bring in, to make sure that the economy is sustainable, and they can have a healthy and a safe family to lead. And of course, the local support is very important in order to protect, in order to prevent further domestic violence. And sharing domestic violence disaster, you can't run away in the refugee camps or whatever happening. It's like in COVID now, in the world, and it happens in the 2014 Ebola. Even they have the experience when you put them in a temporary shelter. I have an experience in one of the country in refugees. The husband is missing in one of the shelter, one of the refugee camps, and he was found in another refugee camps with another woman. So that was where the issues of domestic violence takes place. So this kind of things happen everywhere, even normal time, even in disaster time, in the refugee camps, and domestic violence is very continuous, and it has to be addressed at all levels. And as I said earlier, One Stop Crisis Center is a total teamwork. It's an integrated partnership between all the agencies that has responsibilities as part of agreed terminology to support and to provide care to the family, particularly the woman and the children. And it is without the support of everyone, including mainly the NGOs, because when it comes to emergency, we do the treatment and everything, and then we refer to a shelter and etc. And that's off it goes at the emergency department. But who follows subsequently, manage them and support them, counsel them, in fact, towards rehabilitation them in the long term is the NGOs. And I must say, without their support, we will be in the loss. And this One Stop Crisis Center, as I think most of us know, and I hope everybody aware of it, that it is established in 1994. It is everywhere in the emergency department. But of course, we don't call it One Stop Crisis Center. We just call it as Bilik Mekar, Bilik Melo, and etc. There is, coded things so that to isolate. I don't want to be stigmatized in the waiting zone of other cases that, that along with the woman that comes to for getting treatment. And this center, One Stop Crisis Center, we provide domestic violence, rapes, and sodomy, child abuse, and these are the cases that comes to us. And our job is to identify them, triage them, look for the early treatments, and then we do the if there is a role of forensic collection of evidence, and subsequently we do the referrals to the psychiatric department, to obstetric gynecology, to surgical side, and then we make sure that the child who is exposed or neglect, they also get equal responsibilities, equal amount of support. And of course, as I say, under 16 has to be reported to police. And of course, the adults, most of the adults who comes under domestic violence are battered women. They tend not to report, because they solely depend on their husband as an economic power, as well as to the matter of fear also. They are worried about the repercussion from the husband, so they don't want to report. So we cannot push, we cannot ask them to to report and etc. So our job is to be more teamwork, professional, and caring, and that is where it has been there from the 90s until now, 2020. we have been the one-stop crisis center, in spite of all the challenges that we have, COVID-19, everything, and then we have non-communicable diseases, heart attack, road traffic accidents, trauma that comes to emergency department. We still have prioritized. We have a one-stop crisis center to prioritize to make sure that we give them the best treatment as possible and put them back to the society as soon as possible with the support of the NGOs. It is the foundation that is worked along all by all the agencies, and without the agencies and guidelines, SOPs and training, we could not achieve the success of One Stop Crisis Center, which is the hallmark of taking care of the domestic violence victims as well as the other violence against women. And it is the comprehensive holistic, as I said earlier, and our objective is among the other things, as I said earlier, is also the legal and court activity through the work of NGO, and to give them emergency management treatment that we have, and the documentation, because subsequently short-term, long-term, the victim or the survivor will need documentation and support, legal representation from the doctors that were attending to her. So subsequently, the objectives has to fit into the long-term needs of on preserving the rights of the victim or the child. And the component, we have 3-level interventions, and it is under the Ministry of Health. We do a lot of auditing, reporting, and a lot of human resource who are trained is deployed. And we work, as I said earlier, with other departments within the hospital, as well as the other agencies within our infrastructure or the government agencies that we have. And the most important thing is for women, it is beside the healing, the acute emergency treatment is also subsequently referrals to other agencies, including inter-agencies. As I said earlier, every agencies are represented for a short while, but the NGOs take them for a long journey and they support continuously, and they have doing a wonderful job until now. And of course, the role of Malaysian Red Crescent, we have to look at how we're going to interface along with the other agencies and look at what are the things that we can provide, what are the things that we can co-share, and how we can share our experience dealing with the other agencies. Of course, the service is, we have to understand, is very private, and it is very holistic, and it's client focused, and it has to be professional. So we have to make sure that we maintain the confidentiality of the patient that we treat at the emergency department. As I say again, in the crisis intervention, we go for the saving life first in acute stage management. So we save life, and then we do all the important process and procedures that can make sure the patient is safe. Then upon stabilization, we do the rehabilitations, we do referrals, as well as the court activity subsequent we take later on. So this is the level 1, level 2, level 3 as our intervention strategy. Again, the level 1 is always physicals. We do the damage control, preventive, and of course it'll end with a shelter. Hospitals can provide shelter, but it is only 24 hours because hospital have limited space and facilities. So we work, as I said earlier, we work along with the welfare department, and then we ask for the support of the NGOs to support the shelter care. And from there, the NGOs is taking them to another dimension. And that's really helpful, because if we don't address this crisis intervention level 1, then the long-term impact of this and outcome of this patient will be not in a good position. And of course, we have a lot of protocols where we use to identify and to care for this patient. And even the shelter homes per se, they have a protocol. So the thing is, guideline is one, SOP is one. How we compromise this is subject to the organization, the internal audit they have done, the training they have given to their staff, and etc. And TRICE protocols are always changing because the crime also changing, and because of a lot of urbanization, a lot of drugs, a lot of habits that is in this current context. Violence has changed its shape and dimension, and violence are happening in a manner that we don't understand anymore. And the work process, as I said, this TRICE is to sort out. Again, we have, if you're walking, you just, bruises or none, you still be managed. But if you are unconscious, when we send an ambulance to the house to pick them up, and to retrieve the patient from the house to the emergency department, and whereby we have to save a life, that is what exactly the TRICE is all about. We make sure that the patient's priority well-being is important, along with the children. So we just don't go to the house just for the sake of the mother. We also work closely with the police as well as the NGO if the children needs shelter and etc. So these are the things that we look, and subsequently, of course, counseling. Yes.
Very, very comprehensive view. And ladies and gentlemen, Dr. Alwi is also one of the pioneer, of this one-stop crisis center. Thank you. It's been very, very interesting and comprehensive. Actually, there are plenty of questions coming in, but in the interest of time, we will keep that right at the end of the session. However, just a time check, Dr. Alwi, we have around 3 more minutes if you'd like to highlight more of your points.
Wow.
I
just
time flies.
Initially, they told me 1 hour. It's okay. I'll take 30 minutes. I'll take a 3 minutes. But as I again say, history taking is very important from our doctor's point of view. We do a detailed physical examination from head to toe. And of course, all the hidden areas will be looked into it. And then, of course, we have a lot of interagency cooperations. We do a lot of referrals. And as well, at the same time, along the line, we make sure that the patient's privacy and confidentiality, as well as the next of kin, are preserved. And of course, we do a lot of investigation, we do referrals, all the investigations sent within the hospital, as well as we send to the chemist center if there's drug involved during the violence of the perpetrator as well as the victim. And further action, further care, as I say, we work closely with the Jabatan Kebajikan or the welfare, and if the police support, we have. So we have both critical and non-critical. Critical patient, as I said, triage according to the condition of the patient. If they walk in, then they go directly to the one-stop crisis center room, which is specially dedicated, where will be met by the doctor. Clocking will be done, and then initial treatment will be done. And with the need to admission both woman and child, we will do the an admission. And of course, we do a follow-up, and then the follow-up also subsequently with the emergency department, as well as the social workers. And then, of course, the police report will subsequently come through. And the crisis intervention level 2, of course, we look at the other, physical management, counseling. As I say again, we go for the investigation, and of course, finally, the level 3 rehabilitation, the court. Of course, this part of it, the level 3 interventions will be mainly by the NGOs. And we have these infrastructures that we have, a lot of facilities, infrastructure in almost all the hospitals the emergency department has, where everybody just walk in, come in from all the other departments to support. And this is the evidence bags that we have created in 94 by the Hospital Kuala Lumpur. Even I think they still have it now, and we have it now. Of course, the human resource, the people who are handling all these survivors are very important, and we have to work in a manner that is, without compromising the patient's interest. And of course, all documentation will be used in court to support. And then the challenges always there, challenges of delays, challenges of support, challenges of shelters, and challenges in finance and budgeting, etc., communication, confidentiality. Sometimes we assume that it is confident, but it is known by others and everything, so that will impact on this patient's psychological support. And of course, the knowledge are very important of staffs and everything. Staff also has to be, resilient, because sometimes they too going through some kind of emotions when they look at the type of casualties, injuries that they are treating. And of course, in conclusions, I must say that we have to look at the early education, domestic violence. The society must understand all religion, all races, they have roles. All the leaders have roles in understanding. We have to train them at the NGO level to hospital level, specific to current understanding the current kind of injuries that the victim can sustain. The need of within the hospital, because sometimes most of the delays can happen within the hospital because the hospital, the surgeons are very busy, and we have to keep the patient or the child in the one-stop crisis center, and then they will take a lot of their time, and we have to wait for police report, etc. The shelter is the other things, and the legal continuity is very important. That's why the NGO is very important. and we have to coordinate with the other agencies, and last but not least, the psychiatric department or the psychosocial support, because that will bring into the post-traumatic stress disorder, not only the survivor, the victim, the next of kin, also the hospitals that dealing with patients who are getting treatment, because some of these patients who comes, they have underlying psychosocial problems, psychiatric problem because of depressed, anxiety, nervous, and they also have other things that which Dr. Umi will explain, and they become violent emergency department. So these are the things you have to look why this woman who are under domestic violence becomes has psychiatric problem and become violent at the emergency department. So that is exposed the safety of the hospital, safety of the victim, and then try to look at the holistic way of how to manage. With that, I conclude. Thank you. Sorry for taking a few more minutes.
No problem.
Thank you very much.
Thank you so much, Dr. Alwi. Very, very comprehensive, very holistic, as you say, services provided. And it's very, very amazing. I mean, I'm very surprised at the statistic you show that Malaysia has like the highest number of social workers ranked in the countries that you've shown just now. And, you know, really, really, really grateful to have you on board. And, you know, just to recap a few of your points, to remind the audience out there, that domestic violence is a very broad scope. We're talking about spouses, of course, even, you know, ex-husband, ex-boyfriend, ex-girlfriends, even, you know, like parents to children, children to parents. So it's a very, very broad scope. And it's the most important is to have, like you said, the social impact circle. To the survivors, you know, here in MRCS, we don't call them victims. We like to empower and say these survivors need this social impact circle support. And of course, your one-stop crisis center is very, very dedicated center, very holistic, and a lot of facilities and support. So do reach out to that center as well. We have a lot of questions surrounding Dr. Alwi, but don't worry, you'll have another, you know, a lot of chance to speak up later. But let's go on to Dr. Umi. You've been waiting for a while. How are you?
Hi,
you are on,
yeah. I've been waiting. I've been listening actually.
Yes.
Thank you, Dr. Alwi, for a very comprehensive background that make my presentation easier, because in my presentation in 30 minutes, I will focus on psychological first aid. So can I start, Siti?
Yes, definitely. So let's have Dr. Umi. As mentioned, she will be talking about psychological first aid and mental health care. Yes, please take it away.
Thank you, Siti. Right. So I have 30 minutes and I'll be sharing psychological first aid and mental health response. And I'll be very focused on a bit of skills. If I can share something that maybe all of you in the Malaysian Red Crescent Society can actually go back home and apply if, let's say, you find a survivor of domestic violence. All right. So maybe we can start by looking at this. This is like from your society, the definition of first aid. So it is something that I think everyone here is familiar. It is immediate assistance provided to a sick or injured person until professional help arrives. So basically it's something temporary, right? Until professional helps come. But the aim is to preserve life, alleviate suffering, and prevent further illness or injury and promote recovery. So from that, what is psychological first aid? So psychological first aid, as defined by WHO and IASC, is a human supportive response to a fellow human being who is suffering and who may need support. And these are two good reference, including the one that Dr. Alwi has shown, the one on OSCC in Malaysia. So this is, I think, from your own federations of societies, International First Aid and Resuscitation Guidelines 2016. There is one chapter on psychological first aid. And this is one, and from WHO, this is one of the most downloaded actually, and the most bought or utilized guidelines, which is psychological first aid guide for field workers, and one of the chapter is on domestic violence. So all of you who need further reading, you can go into these two guidelines and the guideline that Dr. Alwi showed on OSCC, because I think if you read these three, you will have comprehensive knowledge on how to manage on how to give PFA to survivors of violence. Okay, right. So we want to look into this background. In emergencies, in crisis, people are affected in different ways and require different kinds of support. This is something that we must have in mind. Meaning to say, when we talk about emergencies or people in distress, the situation can be for example, in a war, in an accident, in violence. But even though it is similar situation, people are affected in different ways based on, you know, their resilience, their background, how they can cope with the situation. So we must take it from this standpoint. And secondly, we must understand that the most basic aspects of psychological and psychosocial interventions are actually multi-layered approaches, meaning we are working together with the emergency department, with the social worker, with so many agencies, with the first responders in actually approaching people, the survivors. We cannot work alone because let's say if they come with severe injury, that need to be settled first. If they need security, maybe police or legal system need to come together. Right. So let us look into the theme of psychological first aid, yeah, the PFA. I think PFA, people talk about PFA a lot during COVID, yeah, even in our psychiatric fraternity, psychiatric and mental health, we are offering PFA. But what is PFA? So if you look into this, PFA consists of providing practical care, right? But we are providing without being intrusive. So we need to do some assessment, the needs, what are the needs, because we want to provide what people needs, not what we think they need, but we need to assess what they need. So we need to help them to address these basic needs. So basic needs first, for example, food, water, safety, sorry. And then we move on to listen to people and comforting them, you know, to the emotional and psychological component, and then help them connect to information and service, meaning link them to the service that after we assess we think they need, and protect them from further harm. So if you look at this, the survivors will need practical care, the basic needs, including, for example, if they are injured, we need to attend to that first, and then only come the psychological needs. But sometimes it can come together, because while we are providing the basic needs, we should always actually look into the opportunity to provide the psychological first aid as well. Right. So what PFA is not, it is not something that only professionals can do. By right, everyone must be able to do first aid and also psychological first aid, but with some minimal training. It is not counseling, not professional counseling, and it is not psychological debriefing. If you have heard about psychological debriefing, it is no more something which is recommended now in any time of crisis. So because the difference between psychological debriefing and PFA is, in psychological debriefing, we want someone to actually inform what happened, the detailed discussion of the event, and this may cause more distress. Yeah? So that's why psychological debriefing is not something which is recommended. But PFA, we do not need patients or survivors to tell what happened in the event, but we want to provide the support which is needed at that time. Yeah? As the previous slide, support can be practical and emotional support. So it is not asking someone to analyze what happened, right? And but it involves being able to listen, being available with them, and not even pressuring to tell, like no pressure to know what happened, and pressure to tell their feelings or pressure to tell their reactions to an event. Right. So how can we provide PFA for domestic violence? So I'm taking this in my presentation. I will focus on domestic violence to intimate partner, or in other words, intimate partner violence. And as we know, intimate partner violence occur more to women, but of course there are also women abusing men. Such cases also occur, but the majority are women are the survivor of domestic violence. So how can we provide? So this is, I think, for us to provide psychological first aid, what we need first and foremost is actually good communication. So we cannot underestimate this. We must be able to communicate. I'll talk more about that. And these are the principles of PFA, being simplified into look, listen, and link. And in look, we want to check for safety, look into the urgent basic needs, and look into serious distress reaction. And then we want to be willing to listen. And because during listen, we will know what support that they will need and will help them to feel calm. And then the last part is being able to actually link them to the help that they will need. So we will talk more, because sometimes when we say to look and listen, it's easier said than done. Yeah? Right. So let us look into this I like this. This is from Australia, actually, how to respond from a guideline to primary care. And this actually simplify the main point when we want to respond to closure of domestic violence by anyone, right? So of course, the most important part is being able to listen and being able to do good communication and being able to validate. Yeah, so we'll talk more about validate. What is validating emotion? Because this is actually the main part of psychological first aid. And here, the word is, I understand it could be very difficult for you to talk about this, but actually, I don't really agree using I understand. Yeah? Actually, it's good to use I can imagine, because we can never understand unless we have gone through similar situation. Like if you have never, for example, being abused, we will never know how it is being abused looks like, right? So we can use I can imagine. And we want to emphasize the unacceptability of violence and be clear that she is not to be blamed. Yeah, we want, because usually the victim of violence, they will be like having long-standing intimidation, being intimidated, being like being accused, being said so many intimidating words. So they have low self-esteem, and they tend to blame themselves, and they think that violence is actually acceptable because they are the one, I'm doing this mistake. For example, my husband said, I should be punished because of this. So whatever it is, we want them to know that, yeah, you may make mistake, you may make something wrong, but to be hit, to be beaten is totally unacceptable, regardless what mistake that you are doing. So we want to know that they are also not to be blamed. And they are also something that we do not want to do. I think in first aid is very clear, things that we can do, things that we cannot do. For example, for someone having accident, you don't want to move them, you want to wait, I mean, because you want to protect the spine, for example. So also in psychological first aid, there are things that we do not want to ask. For example, the why question, maybe we want to leave that a bit later, like, why don't you leave? This is like so bad situation. Why don't you leave him? Why could we have and maybe asking like, why did he hit you? Like the event, asking the event. This is something that we don't want to ask also. And what could we have done to avoid this situation? Because this will make them feel like as if they are not taking any effort. Like, have you not talked to your parents? Have you not talked to anyone about this? We do not want to ask those questions. Of course, we can ask later after we are giving the psychological first aid. We can ask later when we want to take evidence, but we want to provide the psychological first aid first. Like when someone is wounded, you want to, for example, clean the wound, for example, before actually go and suturing or doing exploration, perhaps. Yeah, maybe I hope the example is not a bit accurate also. Right. Okay. So now we'll talk about the emotional validation skills needed. I think I skills needed for skills that we need for to actually provide psychological first aid. And these are a very, very important, I think I'm sorry, I'm really sorry, I need to actually charge my...
Oops, I think we lost her. No problem, Dr. Umi, take your time. Meanwhile, Dr. Alwi, what do you think about the topic? PFA, very interesting. I was learning this new terminology, so it's psychological first aid.
Yeah, there's a lot of champion. I think Dr. Umi is the one champion that has to produce more leaders in dealing with PFA. And I can see in my group there's Dr. Afida. She's also an ONG specialist, etc. There are many. Of course, you get to be excited. You have to be resilient. You have to be sustainable. And this psychological support, as Umi said, it is not one time off. It is lifelong. So.
Definitely, definitely. So, well, while waiting for Dr. Umi, probably we can, I've heard about the recent works that you guys did in Sabah. Recently when Sabah COVID cases was really, really high, and there was this, I think, was the mental health hotline, I think, to call, held by the MRCS, as part of the hashtag Response Malaysia. I thought it was brilliant. And how do you think this PFA applies there? What do you think?
Well, that is one innovative, creative. It has been there for a long time because I think a lot of, if you look at the befrienders, they'll be using all these lines before, and supporting those who are need in support, particularly towards suicidal and alcohols and everything. Of course, during COVID, the Malaysian Red Crescent has started on the online supportive initial support. Initial intervention, of course, later on will be face-to-face, psychiatric assessment and support, and it is going to be forever. Now itself we're doing a lot of Zoom, presentation, etc. So the technology, the artificial intelligence, all these technologies that we're using, including drone, all be used to handle the psychological first aid needs. And as I say again, every house. Like we used to say, you need one person to understand CPR. Now every house must have who understand PFA, psychological first aid. So
totally, and it's brilliant. I am so glad to see that your one-stop center also provides this kind of training and exposure. I hope like a lot of public will be able to support, because it all boils down to social, like you said, it's social circle, your friends, the person that you feel safe to talk to. And indeed at MRCS we really encourage this. And we want to reassure everyone that it is safe to speak up if you are a survivor of this kind of incidents. And there is no stigma of getting counseling. It's really actually great that you acknowledge that you need it and then you seek it. Brilliant. I think Dr. Umi is in already. Would like to hear more from you. Dr. Umi, are you there? Oh, she raised her hand, I think. But we can't. Yes, I am here. Yes. Could you please turn on your video? Is it working? Okay, she's back. Okay, thank you for the patience, ladies and gentlemen.
Yeah, thank you.
There we are. Thank you. We missed you for a while there.
Needing psychological first aid. Yeah. For that. Yeah.
Great to have the teamwork. Okay, please, Dr. Umi, continue.
Okay, right. So just now we talked about the skills needed to provide psychological intervention, and we call these skills the emotional validation. Yeah, because when we talk about giving empathy is a very big word. So how do we behave when we want to provide empathy, right? What we are going to say when we are saying that we have empathy? Because empathy is something that you feel, but you must express it so that the other party will be able, to feel that they are being empathized. So there are ways to do that. So the skills needed is first our willingness to sit with feelings and emotions. So this is a state of mind, because sitting with feelings and emotions is not easy, especially like because you need to listen. You may feel awkward, like you do not know what to say. Yeah, sometimes, oh my god, I do not know what to say. This is like, so some people are not willing to sit with emotions. So but this is something that for us to provide psychological first aid, we must have this first, the willingness, the state of mind to be able to feel with other people. Like empathy, people will say like wearing other people's shoes, but I cannot actually relate to that. To me, it is actually feeling with the people's feeling, trying to feel how the other people feels in that situation. So that is the first prerequisite for us to be there. And sometimes some people in a very distressed situation, this is all that they need. Someone to be there, being present with them, and not being present physically, but emotionally as well. And they can feel. I mean, you know that you can feel when you talk with people, and that people really listen to you without them saying anything. And let's say if you talk to someone that people is present but actually not listening to you. So sitting with emotions is what is this? Yeah, like being emotionally present. And when someone very distressed, sometimes you just need to be there. Sometimes you just need to say minimal words. Sometimes we need to allow silence, because sometimes we are awkward with silence. We feel like silence is something that we cannot afford to have. But sometimes silence is something that we need, that person need to reflect, to answer to our questions, and for us also to gather ourselves. Right. And second thing, what we can do is actually to do accurate reflection. This is one of the easiest thing to do, because sometimes we do not know what to say, but what can we say is basically reflecting what the patient say. And this is actually showing the survivor that we are listening. For example, if that person is saying, I feel so confused, for example, right? Say that, then you can say, yeah, I can hear you that you are feeling so confused. That rather than oh, what am I going to say? And then we might say something, yeah, just become like too quick reassurance. Sometimes it's not what we want to do in psychological first aid. And then we can move on to name the emotions. For example, like say that maybe the survivor will not say her emotion, but you can see like she's very distressed, very restless. Then you can call her and say, I can see that you are very nervous, you are very anxious, you must be very scared. So this is something that we can do also in psychological first aid. And then the normalization of emotions. Of course, you feel scared here. I think this is the first time that you come to emergency department, for example. Or this is like maybe she ran away from home. You must be very scared. You are away from your home. Like normalizing the emotion, not normalizing the violence, but normalizing the emotions. So all these skills are very important skills, the emotional validation, when we want to actually help patient. So we can use, this is the examples that I have mentioned, that remember, when you look and listen, you can use your senses to actually say something, yeah, as a starter, that I can see that you are so nervous. What you see, you just mentioned, looks like you are so scared. I can hear that you are having mixed feelings. And then you can keep quiet. After that, listen how the survivor responds. Sounds like everything is so confusing for you. I can imagine how difficult and frightening it was. Yes, so we don't want to say, we want to avoid saying, oh, yeah, say faham. Oh, yeah, I understand. It's difficult. You try to use, I can imagine, because that is honestly what we do, right? We imagine what happened to them. We don't really understand. We only see them for, like how many minutes, right? And then we want to actually inform them that these are also possible validation statement, like uh, everyone deserves to feel safe. You don't deserve to be hurt. It's not your fault. Even if you make mistake, it is unacceptable for you to be hit. And I'm concerned about your safety and well-being. You are not alone. We are here to go through with you with this. Whatever you decide, help is available, and you are not to blame. Abuse is actually happening to many people. Happen in all types of relationship, right? So yeah, we can say yeah, abuse can affect your health and many things. You know, this is like neutral feeling, normalizing, showing them that we understand, that we empathize. As we can see, we are not too quick to give advice. We are not too quick to moralize or give reassurance, right? We don't say that you will be safe. You know, we don't say like you must be, for example, you must be patient. You know, we can say that, but not too quick, because in the beginning we would like to have some space so that the patient feeling that they are being heard, being empathized, the emotion being validated, then only they can become calm. Because actually to name emotions is to tame emotions. Name it, to tame it. You help, like you call people, right? You call by their name, you call emotions by their name. So the emotions will be tamed. That's something very important that we want to remember. Right. So, and then this is something that Dr. Alwi also mentioned, yeah, like many times, of course we are puzzled why a woman can be in that kind of relationship for so long, for example, and they don't want to make report. Or sometimes the police also quite frustrated. A woman make report, after some time they have worked out on the case, and then they tak jadi, they withdraw the report. So, but this happened because to understand this, we have to understand the cycle of abuse. Most of the time, women are too terrorized to be able to always protect their children, and to worn down by repeated violence to seek help. They are in a situation that they just can't think what to do. They are living in fear of violence, the threat. They don't feel that they can even move even 1 inch. How about to go and make a report? And they are in real fear of losing their children to authorities, whom they fear will disapprove of their home life and take the children into care. This is like, okay, the situation, because a child protection may come and see the situation, because usually they will be substance use, there will be violence, and the children will be taken away. And sometimes they are also abusing their children, so they feel that they are very much at risk to seek help, risk of losing the children. And sometimes they are being intimidated by the husband. The husband will say, whatever it is, do you think you can get your children? You are too bad. You are not working. The children, will be mine. Things like this. This threat will make them being unable to go forward to make report. And they are unable or reluctant to recognize the cycle of violence. This is the cycle that we need to understand when violence occur. And this is the cycle of violence. Usually in violence, what happen is there will be a honeymoon period actually after each violence. This is established cycle of violence, yeah, in typical violence. They will, but after honeymoon period, then will be tense growing, and then serious battering incident, and then honeymoon period again. And women being women, they are forgiving. They would like to give more hope. They would like to think that their children will still have a father figure, things like that. So they will continue giving another chance and another chance, but ultimately they are trapped in this learned helplessness. Yeah, the psychological term is learned helplessness, whereby they are trapped in this in this situation that they cannot find a way out. So that's why actually it's not surprising at all when they do not come for help, right? So this is from the guideline from the IFRC, and I think this is a good one. Sorry, the basis model, whereby it actually summarizes what we do. In the beginning, of course, you want to introduce yourself, and then you want to acknowledge, recognize, and ensuring feelings. Basically, this is where the emotional validation should take place. And this is very, very important, because once actually the patient feel that they are being validated, being heard, being understood, then the next steps will be easier. The cooperation, the engagement will be easier. So if you don't pass the A, the acknowledgement, actually we don't want to move to the next step, because usually they cannot even listen what we want to plan for them, because they are still very much inside their emotions. So next will be the structure, providing security and structure, and also giving them information, how to help them, and then link them to the social network. So I think this is a great model in the IFRC guidelines. Okay, should you tell the husband? Yeah, should you talk to the husband? The answer is most of the time no, because we want to avoid confronting the abusing spouse of the family member. So just now, there is one good question, like how to actually recognize the victim of abuse, because usually they won't tell it straightforwardly, but we can recognize them by maybe one, by injuries which are not consistent. The story between the injury and the story looks like not consistent, not tally. That you think that this injury doesn't really, the injury happened, but the story doesn't relate. For example, dia jatuh, but the injury is so bad, things like that. So you want to suspect maybe abuse had occurred, and then maybe frequent visit, and then you can see that they are, they have self-blaming towards themselves. They look depressed. They look like they are having low self-esteem. Or when the husband actually insists to be there all the time during the interview, you must suspect that also, because maybe the husband is so scared that the wife will actually reveal something. So and sometimes abuse can really occur, very with very non-specific symptom. I had one patient who actually presented to surgery with breast pain, and surgery had investigated, referred to chronic pain, but finally, after many sessions with surgeon, with chronic pain specialist, she actually revealed she's actually a survivor of domestic violence, and that pain is actually an excuse to avoid having intimacy with the husband. But of course, the pain is real to her. She also do not know why she's having that pain, but actually after we address the domestic violence, the pain went off. Yeah. So we don't want to tell the spouse, and we really need to be careful, because usually most of the time we would like to take corroborative history in health setting. We would like to know from next of kin what happened, but in survivors of domestic violence, perhaps this is something that we don't want to do very quickly. And then again, also this has been mentioned by Dr. Alvi, should you make a police report or ask the women to make a police report? The answer is obviously no, unless it involves child abuse. We do not want to force the domestic violence survivor to make a police report, and the survivor has the right to refuse police intervention. The survivor shall be assisted to lodge a police report where appropriate. So we want to actually, but if they are actually having mental capacity impairment, for example, learning disability, so we have to look into guardian to look into this, maybe to make decision for that person. But a police report can be made, and a police report can be made at any time and should not delay the initial treatment and examination of the survivor. There are many reasons why women do not want to make police report. Actually, it's not surprising at all. For example, if it is sexual abuse in the family involving family members, that is really a very complex situation where a police report may be not an answer to that question, but rather more of being in therapeutic in therapeutic session, whereby psychiatrists come in, help to do family therapy rather than going to do a police report. Yeah, but of course we need to discuss all this with our survivors, right? So how are we going to ensure safety? And this is the most important part also, the mental health response, because we know we must not forget that first aid is temporary before linked to the professional. So, but of course in minor injury, first aid will be enough. You don't have to link them to professional. But I would say violence is not minor, so most of them will need more support, because there are lots of things that need to be addressed. But safety first. Usually, safety will be the first thing. After the validation, we want to ensure safety, and we are going to look into where to link for the continuing care. And when we want to assess safety, sometimes we must ask ourselves, is it our own anxiety that we need to address? Because we have to trust our patient. They have been living in violence, and we want to look into evidence how severe the injury is, and victims' own perception of risk. If they say, I think I'm still safe to go home, plus our own professional judgment, all this must combine when we assess risk to allow patient to go home or to actually work for protection. So we need to look into many factors. For example, does she feel safe going home after the appointment? Because, after the first disclosure, someone started to know about the violence. This is actually the most risky period. So we want to know whether it's safe for her to go home. Are the children safe? Does she need an immediate place of safety? Does she need to consider an alternative exit from your building? So all this is something that we need to ask, we need to assess, and we need to link maybe to social worker or to other family members. Usually in a mental health setting, we would like to have social worker come into the picture, because they will actually give more good information about the protection available, so that this survivor can make an informed decision, right? And then if if immediate safety is not an issue, for example, the decision is for her to go home, so we want to know, does the husband or he have weapons? Does she need a referral to police? Does he have emergency telephone number? So we want to make sure the plan of exit for her, like where would she go, how would she get there, what would she take with her, who are the people she could contact for support. So this must be prepared for her. And usually we actually advise them to have everything, all important documents, keys in one bag actually, so that if they need to run, they can actually pick up the bag. Yeah, so this is a good plan for them.
Right. Dr. Umi, I feel so sorry to interrupt you, but just a time check, we have another about a minute. If you like to wrap up.
Yeah, this is my last slide, Siti. So consider your patient safety, and we want to actually not making decision for them, but empower her to take control on decision making. So we want to actually correct all the misunderstanding that she has, for example, about custody, about what will happen to her, about the protection. So empowerment will help her making decision, and respect the knowledge and coping skills that she has developed, and actually provide lots and lots of emotional support, ensure confidentiality. And for us, to help them, we must be familiar with appropriate referral service and their processes. So with that, I think we must remember that bruises physically is something that we can see, but the wound inside one's heart and the scars inside one's mind is something that we cannot see, but still something very crucial for all of us to address. So thank you very much.
Thank you so much. That is such a beautiful wrap up that I've ever heard. Thank you, Dr. Umi. And ladies and gentlemen, just to inform you, it's a very honor. It's an honor to have Dr. Umi as well, as she is the only one in Malaysia who was trained in family and prenatal mental health. A very comprehensive and interesting coverage of the topic, Dr. Umi. And indeed, mental health is, trending nowadays, and I do not say that in a way that we should be proud of, but it is something that happily been talked about. And we have plenty of questions from people, but I'd just like to wrap up some important things from Dr. Umi's session. So we talk about PFA. It is not a psychological debriefing, and we shouldn't pressure people, to find out more. Or in other terms, in Malaysia, we call it membawang session. So it is more importantly, we look, listen, and link, and do active listening, as you say, to mention that we understand, and not to mention we understand, sorry, but to say that I can imagine what you're going through. So that's very great. And emotional validation, such a simple tips that you gave, which is just to name the emotion that is already taming it. It's brilliant, I found. And of course, we have all the models and all the, the cycle you were talking about, the honeymoon, the tension, the explosion, a very, very good indicator, as well as, what the steps that they should do, actually in contrary of what people think. You don't go to the police immediately, or you don't talk to your abusive spouse or abusive parent or children first, but you check, you see these indicators, whether the injuries don't match, like you said, if they have low self-esteem. And of course, you try to provide for their safety and check for future safety and continuity. Brilliant tips. Really happy to hear all those things. Now I'm just gonna shoot questions to both of you. So we have a lot of participants, as of now 243 participants online, and even our beloved National Chairman of Malaysian Red Crescent Society is online today via Facebook, yang teramat mulia, Datuk Seri Diraja Tan Sri Tunku Puteri Intan Safinas. And she's asking whether we should also consider the issues of violence against children and against male victims. So I leave it to the panelists if you'd like to answer, starting with Dr. Umi, perhaps.
Yeah, of course. Yeah, thank you for the question. Of course, for children, we also have like a very established OSCC for the children. Actually, in fact, I think maybe if I'm not mistaken, Dr. Alwi, I think the children part is much more established compared to women. Yeah, because usually for children they have compulsory reporting. There will be people who the team is quite established, consists of a pediatrician, psychiatrist, the social worker. They have regular meeting. But for the women, I think it's more complicated because we need to tackle that more sensitively. Like maybe they don't want to report. Yeah, they want to come just sessions for therapy. So it's a different way of approach. And for men, yes, also because and I think this is really a very neglected area. Yeah, maybe someone has to take the lead for this.
Yep, let's jump to Dr. Alwi. You should take the lead, possibly in this area.
Yeah, Siti. Yeah, the thing is about under the Malaysian law, the Child Protection Act, really protects the interests of children. But bear in mind, the mother and children, these are vulnerable group. They are high risk. When there's violence happens, children, they witness a lot of incident at home, and they can mimic what the parents do. And they have a lot of impact on their educations and their growth, their nutrition, their mental health care support. And they also will be victimized, they also will be abused sexually, physically, and everything. So based on that, the one-stop crisis center, if they come, if the parents or the neighbor or the police or the welfare officers or the NGO brings, it is our job in one-stop crisis center to isolate them, and then based on their triage about their physical and mental assessment that we do, we will prioritize the treatment, and subsequently they will be referred to a suspected child abuse and neglect scan team, which will be led by the pediatrician, and they will be warded if necessary, where there will be an integrated approach by the doctors, the pediatricians, the psychiatrists, as police, as well as NGOs that all come in, and the social welfare will come in. If there's a need to isolate them, put in a shelter, and short-term, long-term. If they need schooling, the Ministry of Health, most of the hospitals in government hospitals, they have a school in the hospitals, so they will have a continuous education in the school also. So there is no interruption, there is no stop towards the development. As I said earlier, it's a holistic approach. We take care of the interests of the child, we protect them. Anybody under 16 years old, we protect them, and they will be given a lot of feedback, and then their family members will be given the feedback. Same time, the mother's need will be addressed to, and the NGO subsequently follow up. So it is not a one-off, it is a continuous sustainability, not only about managing the survivors, as well as make sure they are resilient and they are rehabilitated back to society.
And I think, Siti, if I can add on,
Sure.
is it also for the perpetrator, like the one who abused, they actually need help as well. And because some of them, they come from a dysfunctional family, has been abused in the past, they may involve with substance use and mental health issues. So actually this is also a neglected area when we talk about the survivors. There are still so many things to do in the area of violence. Yeah.
That's true. And thank you. We have great leaders such as your good self and Dr. Alwi as well to help us in this. Let's go to the second question. We have another one from Facebook as well, from Muhammad Khairin bin Rusli. So he says, a person with no background in medical or psychological, referring to himself, how can we determine that someone is suffering from abuse? How can we identify the sign symptom, and how can we assist the victim if they refuse to seek help? I believe the first part of the question you already answered, Dr. Umi, but the second part that is very important. If the not the victim, if I may reward it as survivors, would like to seek, they do not want to seek help, how do we do? Yeah, please, Dr. Umi and Dr. Alwi.
Yeah, Dr. Umi.
Okay, I think there are many reasons why people do not want to seek help. The help-seeking behavior, right? Sometimes they do not know like where to seek help. They do not know like how people can help them, and that's why part of it is creating awareness is what we can do, and then in our health place actually is good. It's a good practice to have maybe a poster saying that we can help this kind of issues. Like if you are suffering from this, you can actually talk to us, because they do not know that this is the place where they can get help. Actually, we have done one national survey on intimate partner violence a few years ago in health clinic, and we found the prevalence is quite low as compared to other countries. And we think that may not reflect the real scenario, because maybe people do not actually be willing to disclose, because they don't think by disclosing what will happen to them. Nobody actually will help them anyway, or actually when they disclose whether confidentiality can be kept. For example, we know that in our health clinic, sometimes health clinic is very locally located. Like sometimes you know the nurse, for example, the clinic desa, you really know the nurse are living around you. And how can you actually disclose something about, for example, your husband to someone else? That is something difficult actually, because to disclose something and to know whether people can help you if you disclose, because like no point you disclose and not getting help, right? So but if we have at individual level someone that we know is having issues, what we can do, we can provide the psychological first aid, like um acknowledging their emotions so that they are more willing to talk further, and then link them to people that can help, for example to the SCC, then that can actually maintain confidentiality and further link to other people. But I think someone who understand, who are able to listen first, empower them, is an important step for someone to be more confident to actually break the silence. Yeah.
Yeah, I think that's absolutely right. Like, first step is possibly to empower them to be able to disclose, their experience and trauma. And this just rightly fits into the next comment made by Mr. Gerald Ong in the comment box. So it is, very important again to create this safe and enabling environment for survivors to, survivors of violence to step forward and reduce the stigmatization. And it's great to hear that the Ministry of Health is also working to create these safe spaces. That's amazing. Thank you so much for that comment. Let's go to the next one. So we have a question from Mr. Awad Hassan. So he is asking, why do you think we concentrate on violence conducted against female and not violence conducted against male? Perhaps we'd like to hear that from Dr. Alwi.
Yeah, as I said earlier, violence cross all gender. So not necessarily a woman, a child, even men. But of course, men being men is always macho, and doesn't want to complain, and he is more stigmatized, and he would be much more worried. And they call it, there's a new saying among the common people, TB, issue of takut bini, they say, these are the common things that it's happening, and everybody will be talking about it. So there is violence, of course. As I say, you cut across both genders, but mainly it is more towards women and men. As I said again, in the year 2001, when I did a study of 256 cases of 6-month studies, there is one man apparently abused by the woman. Why? Because one of the reason is, since it's a very open thing now. The wife was working as a GRO, and apparently, he has advised her not to go to work and everything, and she started abusing. Because I'm sure she also under the influence of drugs and etc. So that's a very rare, very very rare, So we do, and currently, modern issues are there: urbanizations, global change, people change, climate change, and we have to look. If the man does not want to go to work, certainly the wife at home will do, every day will be telling them, go and find a job, etc. So do you consider as a form of a physical or emotional violence? Perhaps Dr. Umi can answer on that. If a husband doesn't go to work and can't find a job, and the wife is telling every day, go to job, I won't feed you or something like that. I won't give you the car key. And is it a part of the physical or emotional violence? What do you think about that? Since the man issue also came up, asked by Siti, not me, Siti.
Please, Dr. Umi.
Yeah. I think we must understand, in abuse or violence, there must be what you call power struggle or intimidating relationship. If someone, quarrel and everyone can talk about their opinion at balance, even though they are maybe a bit rude, saying verbal nasty words, that is not abuse actually. Abuse is when someone is actually as if having a higher power in intimidating relationship compared to the other. So if, let's say, the wife hit the husband and the husband can hit the wife, so maybe that's not really abuse, because in abuse usually the wife will be so scared that he cannot actually that he will not able to hit the husband. The husband is the one who will always hit or beat the women. So for men, macam mana takut bini tu? Katalah macam
but
emotional abuse.
But these are common things in a real life,
Yes.
But as I say, it's a very remote and very rare. And men do not come and complain, unless you really need to be intubated or warded, put into ICU, that is. But mostly it is women who comes with, even we have stab wound injuries, burn injuries, and when pushed from first floor, etc. That's very common.
Ouch. Yeah, I think, Dr. Alwi, if I may add, I guess this is all as to how men are expected to behave, isn't it? It's from childhood. I mean, you're not supposed to express your emotions. It's perhaps takut bini part, but it's also like, they're not expected to whine. And for women, it's easy. We are more expressive, more easily we can express our emotions, whatever trauma we're having. And it was interesting to hear the statistic that you mentioned about the case study, the 265, only one man came up and actually say that, hey, I'm being abused. Very, very interesting about this power struggle issue. That's great. Let's go to the next question. We have one from Nur Afida Mat Yusuf, and she says, "Salam, Dr. Umi. I'm a PFA trainer, but professionally working as ONG specialist. One of the challenge in doing training is the stigma that PFA only can be provided by counselor and professionals. What is your view on this?" Love this question.
Yeah. Thank you, Afida, for your question. I think that's a very important thing that I think in the beginning of our slide, we are saying what PFA is not. It is actually not something that can only be provided by professionals. So everyone can be trained with a short training. Even now, with just, if we know to do emotional validation, we can actually provide psychological first aid to anyone. So I think more awareness is needed because actually PFA, being able to validate emotion, is something that we can use in all settings, not necessarily in distress, right? Even in our communication with other people, even when we communicate with our spouse, when we communicate with our children, we can actually always acknowledge emotion. We can always help them to cope with things, to problem solve issues. So I think solution to that is still to have more awareness and to correct the misconception that PFA is for everyone, and it's good that everyone know the skill because it will help you in all aspects of your life.
Brilliant, thank you so much. And another, maybe a refresher of what PFA is. It is psychological first aid. Actually, I'm saying that to myself to remind myself. And it is indeed everyone's role. Right, let's go to the next question. It's from Muhammad Aiman bin Muhammad Ashraf. So, well, he's telling a story about one of a friend who has been raped by the father, but did not say anything since, you know, she's afraid of whether the family will hate her. And he's actually asking how to support this friend who's currently a survivor of sexual violence. Would Dr. Alwi like to say on this one?
Well, as I said, when it comes to family members committing a crime, it is very sensitive. It is also very something that they like to keep it, low. They're worried about stigmatized. They're worried about their family institutions. They're worried about the economic, social support, etc. However, one has to talk. One has to reveal. One has to talk to the next of kin or colleagues or NGO or the hotline call. Use the hotline to ask for support in private. Of course, the consequence will be, it will be traumatic for both the family as well as the survivors. Now, the thing is, certain things has to be put to a stop, and it can't go on because ultimately we need to address the mental well-being of the child or the girl who are growing. And there's a lot of NGOs are willing to support everything. The hotline is there, and nowadays social media is very accessible. Anybody and everybody can call, and they can have a private arrangement, and they can reveal. And of course, the other way is going direct to the police, which is impossible because family ties are very strong. It's very difficult. Sometimes the mother himself try to, it's very rare, but mother himself trying to, close up the matter, or the brothers and everything. It has happened, the incest they call it. Perhaps Dr. Umi can want to share on this.
I think the Alwi is right. Like many people will not reveal what happened in their family. That's very common actually for so many reasons. Of course, they don't want their father to be caught by police, arrested, went into jail. They are going to lose breadwinner. But usually, what's important for them is the mental health sequelae. Those who develop mental health sequelae is usually those who are invalidated of their experience. For example, if a child being raped and then this child went to her mother to inform what happened, and then the mother might say, please don't tell anyone, or I think this is because you did this and this, that's why you are being raped. This is like invalidating remarks. So these kind of children are those who are going to have high risk to develop mental health sequelae. But those who are raped and then get validation, for example, the mother maybe will, oh, this is not acceptable, and immediately do something to protect the child. For example, move. Sometimes, yeah, sometimes make police report. Sometimes, if not, maybe make arrangements so that there will be no encounter. So the child will feel safe. So the validating response that she give actually can be a protective factor to someone from developing mental health sequelae. So if let's say someone has had a history of being raped or molested or abused and apparently not receiving validating response, they may need help later on in their life because they may develop many like a spectrum of mental health problems like depression, anxiety, post-traumatic stress disorder. They can even develop sexual difficulties. For example, maybe when they get married, or they may even have difficulties to develop trust to other men and have significant relationship in the future. So definitely they will need help, and maybe by validating their difficulties, giving information will help them to come forward and to give and to actually get help. And we can inform them that you can get help even though you don't want to inform about the previous abuse, because sometimes that's what they are afraid of, that when they come, people will ask them to make report.
Yeah, that's great, because that brings back to the first point I think you made on PFA, which is, not to force people to to reveal all the details of whatever happened to them, but just most importantly for them to, feel safe to speak up on this. And the thing you mentioned about the mom saying like, no, you shouldn't report about this, it's very much, I believe, like the Asian, more towards Asian society, to save face. But yeah, I mean, it's very, very important to make the survivors feel that, yeah, you should come forward and it's very safe. We don't want to know the details, but, we'd like you to seek help. Very, very good explanation, Dr. Umi. Thank you so much. We have another question from Ita Ting. So there is, actually, it's more of a comment. So she's saying, she or he, I'm sorry. Another point to stress for us to be part of the solution rather than to be part of the problem would be to change the mindset of everyone to be socially responsible in educating himself or herself, especially educating the boys and men so as to shift the social and cultural norms that define manhood to be taken more seriously, as there is a lack of addressing the perpetrators or abusers' rage and anger deemed to be the norm to be in power and to control. So I guess this goes back to your comment on part of the help should be supplied or channeled to the perpetrators. Yeah, very good one. Let's go to the next one. We have Dries de Bok, who is asking, what is the best study program at university to become a social worker? Or are there many options? So I guess this goes back to qualifications. Would anyone would like to take up the answer? Dr. Awi, we haven't been hearing from you. Perhaps you'd like to.
Yeah, social studies. I think there's a lot. If you come from a medical background, then you have to do about domestic violence as a subspecialty, and you can do a fellowship. If you're a non-medical background, then you can join the NGOs. NGOs offer a lot of courses, short courses and long courses. Of course, you can take degree courses in social study or psychology, and counseling. So these are the things that you can look. If you are interested to pursue on this kind of specialty, and perhaps psychology will be good and counseling will be good. I think Dr. Umi can explain about the opportunity in career advance for those volunteers who, both in Malaysian Red Crescent, who are keen to take up, because this is the impact, the future impact. Family institution is going to have an impact on the economy, political, social, in our culture, in our life. And this is the kind of area that we have to invest, because we will be the engineer in in remodifying all the risk factors that exist. and looking at all the identification groups, the vulnerable group, and then we have to mitigate the hazards that are going through by the family members, and we have to get more professionals involved, particularly a learned one to support. What do you think, Dr. Umi?
Yeah, yeah, definitely. Mental health. We need more human resource in mental health professionals. I think that's a fact. We need psychiatrists, clinical psychologists, counselors, and also social workers. Social workers is also the very much under resourced because they need to do so many things. Do psychosocial assessment, child protection, and what we can see in Malaysia, even child protection, they cannot cope protecting our children. Even though on paper they need to be child protector to like a number of people they need to visit, for example, but they just can't afford to do that because there are not enough manpower. So we know sometimes we refer and the children is under child protection, sometimes no visit at all for a year, but we are actually working within very much limitation. Um, and I'm not really sure how to go about studying to be a social worker, but there are different pathway to be different professionals in mental health. You can go to study counseling to be a counselor. You can do psychology and then masters in clinical psychology to be a clinical psychologist. And you can learn medicine and be a psychiatrist and subspecialize in women, for example, or in areas related to this.
Right, right. Yeah, glad to hear a lot of interests are coming in from the crowd today on the topic of mental health and getting some qualifications to help people. Dr. Alwi, you're still on the line because we have another question from you from Matnir Fik. Are these or is this one-stop crisis center exists at all hospitals in Malaysia, or does it only exist in the hospital of KL, so HKL?
Okay, good question. Thank you very much. On behalf of Ministry of Health, we like to say that the One-Stop Crisis Center, which was developed in 1994, which was started from HKL, now it is available in most of the hospitals, the small or big. But the district hospital may have, but the smaller hospital or clinic kesihatan, they get a case, they refer to the tertiary hospital. So it is a place at the emergency department, but normally it is not the open area, it is hidden for safety and security and confidentiality purpose. The medical officers are well trained. They can identify cases, and then they have a special channel to go to the one-stop crisis center room where they'll be attended immediately. And if it is an emergency, then it'll go according to the zones that we have created, according to the zone, like life-saving process and procedures. So it is there, yes, and we normally get cases from the NGOs, police, social workers, neighbors, even some of the good some good Samaritans. They bring in cases and everything. So our job is to sustainable. We have an SOP. We have very good collaboration with our partners, particularly pediatricians, psychiatrists, police, even forensic, and etc. So legally, we have a legal binding towards this one-stop crisis center, and we also attend to the court, and we also give a lot of evidence, and we also treat the emergencies. Yes, we do.
Right. Thank you very much. Very interesting. At least we know that help is just a stone throws away. Thank you very much. We have a very engaged participations, and as we are left with only 5 minutes to the normal scheduled time, but I would like to ask if you both are okay to take a few more questions because people want to know more. Dr. Umi and Dr. Alwi, you are okay to take two or three more questions?
Yes.
Yeah, okay, perfect. Right, so let's jump into the next one, which is a really interesting one. From Almas Sayuni. So if the domestic violence does not involve physical abuse, but like using children, intimidation, isolation, economic abuse, and usage of male privilege, how can I make a difference as a child? Okay, I would like to understand further this question as well, but I guess the person is asking as a perspective from a underage, possibly. Dr. Umi, would you like to take up the question?
Okay. Of course, physical violence maybe can be more obvious, even though I have said so, sometimes it's not obvious as well because they don't reveal. They will give fake stories behind the injury, but the emotional abuse, social abuse, sexual abuse is something which is actually more subjective. Yeah, most of the time for us to actually test out whether this is an abuse or what. So we must understand. I can see that there is another question also asking which one is actually worse between physical and emotional abuse. I think we must remember for each physical abuse there is emotional abuse, because how can a physical abuse occur without emotional abuse? So emotional abuse is occurring for all abuse, I would say. But of course, there will be emotional abuse without physical abuse. And using children, intimidation can be abuse. Yeah, isolation can be abuse. Economic abuse, for example, controlling, not giving money, stalking can be abuse as well. Using male privilege, yeah, this is the controlling behavior. If you read even in the OSCC guideline, I think it's mentioned quite clearly what are considered as abuse. So all this can actually reach boundaries of abuse. That's what I would say.
All right, that links to the next question, perhaps for Dr. Alwi. It's on the same topic, actually. It's saying that how can a child seek for help if they can't express themselves, and most of them don't know what they are facing, whether it's a kind of physical or mental abuse. I mean, yeah.
Well, good question. Thank you very much for the question. Child is an asset, and they are the future leaders of the country, and we need to protect them. So we have a Child Protection Act. The Child Protection Act, under 16 years old, it is mandatory that any child, even below, if you take a child, then it's below 12 years. If it comes to rape, under 16. So any child, we have to be protected. It is a job of the doctor or the NGO or the police, either brought by their parents, either brought by their next of kin or uncles or NGOs and workers, because this is how they come. And normally, if it is not from the parent side, it is a neighbor, it is someone who they know, so they will be brought to us. And we have to apply our SOPs. They have a SCAN team, suspected child abuse and neglect team, which will immediately attend. And we also give 24 hours, can be warded, and then will be further assessment, because it's very difficult. A child could not express. Child can they may not give us information, and we cannot rely the information provided by the adults too, because we are independently will assess them. The police will assess them if they go to a police station, because they have a special unit under domestic violence child protection, and then it comes to hospital, we have a different process. So at the end of the day, the child will be privileged, and to be documented. And if there's a need to, almost all the child that comes to emergency department will be reported to the police, because without a police consent, we cannot do the investigation. So we do not need the parents' consent also when it comes to children. So that's how the law really protects children.
Yeah, that's a very straightforward thing, eh? Compared to like you said, men and women, they don't really have a specific. Yeah, it's a little bit more complicated, the mechanisms in terms of stepping up and speaking up. That's great. We are going to address another two, if you don't mind. There is a question on. I quite like this question actually, because it is a part of DNI. So how do we address violence and rape in indigenous communities when it was or still accepted culturally? So we'd like to hear from Dr. Umi, if it's possible.
Yeah, this cultural influence in domestic violence is the factor which make things more complicated actually. For example, even yeah, maybe in some indigenous it's still like a culture which is acceptable, but in overall Asian culture there is also some what you call patriarchal, yeah? Some patriarchal like we must treat the way women and men interact, and some even misinterpretation, like it is acceptable, for example, a husband to beat the wife, and for example you shouldn't seek her membuka aib, but actually these are all misconception, even in some misconception in religion, for example, yeah, that one, because actually you can ask for help, and actually it is still not acceptable for men to beat wife even in Islam, and actually men should be the best person to their wife. So when it is something cultural, it is of course something more difficult because the word acceptable. So we want to actually first correct the misconception, and then uh, promote or advocate that it is actually unacceptable. I think that is the most important aspect. The fact that violence is unacceptable regardless of what happened. For example, even the simple things that you can, I make mistake, that's why my husband beat me. For example, some survivor may say that, but we need to challenge that because she is accepting something which is not acceptable. Like you can make mistake, but you can't be beaten. Can't your husband talk nicely to you? Can't you ask for forgiveness? Things like that. Of course, we are not going to say that in psychological first aid. Yeah, we are not going to confront like that. But we need to actually conveying the message about unacceptability. Keep conveying that message, whatever it is.
Right. Thank you very much. Yeah. Thank you to Nisa Maris who actually brought up that question. Really good one. Okay, so I think we will end with this question. It's from Adam Daniel. So does this place have consultation for someone who's mentally hurt because of domestic violence? Now, before I leave it to the panelists to reiterate what kind of options are available to the participants or the interested audience out there, yeah, there is the emergency services such as police, fire, medical. You know, you can use 112 or the emergency lines. I think which is 15999 is the hotline in Malaysia to disclose situations of domestic violence. What about, yeah, maybe the panelists could help again to just summarize and reiterate what kind of, you know, steps and actions and, you know, practical actions that they can take. Please, Dr. Alvi, if you'd like to start.
Okay, public who have issues related to any issues related to domestic violence or mental health care, they always access to a lot of NGOs hotline. Yeah, they have. Even if you Befrienders is there, Awam is there, Women Action organization is there, Sisters in Islam is there, and these are the 24 hours, and they're always available. And there's also a Kementerian Kebajikan Wanita, Talian Kasih is there. So, and of course, in emergency, situation, you have 999 service, where even our Persatuan Bola Sabit Merah Malaysia, Malaysian Red Crescent Society, we have ambulance office. Currently, our pengurusi yang teramat mulia, Tengku Sapina Sintan, has directed us to help and to train our first responders, particularly in the hotspots, ambulance, as well as the other ambulance that we have, to approach according to the SOP set by the Ministry of Health on the domestic violence cases and mental health care challenges. And we work very closely with the hospitals as well as the police and etc. So we have multiple, as I said, current world today is the world of technology. Disruptive technology is there, so we are always accessible to social media, online, hotline, and everything. So, or else the worst case scenario, you just can walk into the hospitals that you need the support mental health care because you are exposed to domestic violence. But it's not as easy as we think, but there is an opportunity. But today's society more open now. They're very expressive. They can put it everything on a Facebook and etc. The only thing is about when it comes to woman, husband and wife issues with children, there's a lot of the approach should be much more holistic, much more caring, because everything there's an impact, short-term and long-term impact to the families, well-being. So this is what Dr. Umi was saying. It is very holistic. It is very protective. It is very soft and tender approach. We want the family institution according to the every race, Islam or non-Muslim or non-Muslim world that we are in, every races or society, religion wants happiness in the family, well-beingness. So we have to approach in a holistic manner, proper support from both governmental and non-governmental agency in order that we like to thank our Tengku Pengerusi yang Mulia Syafina Zintan and all the NEB members who are continuously from the Malaysian Red Crescent looking at how we can help our community.
I think Dr. Alwi is a bit breaking over there. Okay, and he has frozen. So, okay, never mind. Regardless, maybe Dr. Umi would like to support his points and make a last call to the audience today.
That's right. I think Dr. Alwi has mentioned quite a lot on how to get help. So maybe I add on a bit on how to get help with regards to mental health. So of course we know that we cannot run away from talking about mental health. We want mental well-being, and mental well-being is when we are able to cope with stress. Whatever stress in our life, we are able to cope. So we acknowledge stress is normal, we are able to cope, and we are able to function. So let's say you find someone has impairment in functionality in three areas. Yeah? For example, work or interpersonal relationship or self-care, that means the mental health is affected. That means they are stressed, but she or he cannot cope, and they are actually impact being seen in these three areas of functioning, meaning maybe they cannot work, they cannot study, or they have difficulty in interpersonal, they cannot trust people, they cannot go on with relationship, or they cannot take care of themselves. So please come and seek help, and you can actually come to see any doctor in klinik kesihatan or general practice and share about your difficulties, and they will assess you and give a referral to a psychiatry specialist clinic in public hospital for you to come and get appointment and see one of us. And there are also many private hospitals, private clinics offering psychiatry and mental health services that you can find. So please come and seek help, because no health without mental health. Thank you.
Wow, brilliant ending. Thank you so much to both Dr. Alwi as well as Dr. Umi for the insightful sharing. And it's been really not just informative, but very, very heartfelt. And, this question on domestic violence is indeed something that we have to talk more frequently about, and perhaps we'll see for another round of webinar with both of you. Thank you very much, and thank you also everyone for staying on. It's 12:10 almost, and we still have quite a number of participants and more questions coming in. However, we have to end it here. Thank you so much for listening. It's been very engaging. So I'd just like to wrap up. A lot has been said, and we will ensure that we'll be sharing some of the facts that you shared just now. But next time when you meet a survivor of sexual and gender-based violence, what should you do? Just like to reiterate these points. We have to listen with a non-judgmental attitude, and we also have to have a timely refer to the survivor to available services if you obtain informed consent from the survivor. So at all times, we have to practice this survivor-centered approach, applying the guiding principles of safety, confidentiality, and non-discrimination, as well as respect. So that's all for today, ladies and gentlemen. We have indeed ended the silence on domestic violence. A jolly Christmas to all who celebrates, happy holidays and happy new year in advance. So we'll see you at the next round of webinar. Watch out for the announcements in our social media. take up our call to join our army of passionate volunteers, including myself, giving back to our beloved society and country in whichever way we can. So stay safe and bye-bye.
Shouting, insult, abuse, violence, rape, pain, tears, fear, shame, stolen childhood. Globally, 1 in 3 women and girls will experience physical or sexual violence during their lifetime. That is more than 800 million women worldwide. For many of them, the threat looms largest where they should be safest, in their own homes. In sub-Saharan Africa, 64% of women have experienced intimate partner violence at least once in their lifetime. 38% of all women murders are committed by intimate partners. Sexual and gender-based violence, or SGBV, is any act that is perpetrated against a person's will and is based on gender norms and unequal power relationships. It can result in physical, emotional, psychological, or sexual harm. Although women and girls are overwhelmingly affected by SGBV, men and boys can also be at risk. No matter your age or background, anyone can experience SGBV. SGBV is an issue faced by communities in all contexts. However, it is demonstrated that during armed conflicts, disasters, and other emergencies, such as pandemics, risks of SGBV are exacerbated. Intimate partner violence, child marriage, sexual abuse against girls and boys, trafficking, and sexual exploitation are on the rise. SGBV is often life-threatening and impacts a survivor's safety, well-being, dignity, rights, livelihoods, health, and many other aspects, both in the short and the long term. The stigma and shame, as well as fear of retribution, often prevent survivors from coming forward. Therefore, SGBV often remains invisible. In situations of disasters and other emergencies, we should always assume and believe that SGBV is happening. There is no need to wait for evidence or data. Most acts of SGBV are perpetrated by someone known to the survivor. This can include people in authority, including humanitarian workers. Sexual exploitation and abuse is a form of sexual and gender-based violence that constitutes an abuse of power by aid workers against the affected population. The abuse is based on gender inequality, power imbalance, and disrespect of human rights. The Red Cross and Red Crescent movement protects vulnerable people from sexual exploitation and abuse by its staff and volunteers. We have a zero-tolerance policy on sexual exploitation and abuse of affected populations, as this is gross misconduct. As the world's largest humanitarian network, the International Federation of Red Cross and Red Crescent Societies is committed to address SGBV. In 2015, our movement adopted a resolution titled Sexual and Gender-Based Violence, Joint Action on Prevention and Response. This resolution clearly states our role and responsibilities as a movement to address sexual and gender-based violence in armed conflict, disasters, and other emergencies. Through our national societies and around 12 million volunteers, our movement benefits from community-based expertise and has a unique reach and access to work on SGBV, including during humanitarian crises. The International Federation of Red Cross and Red Crescent Societies supports national societies in the long term by building their capacities to prevent and respond to SGBV. We support authorities to build back better national and regional systems to address SGBV in situations of disaster and other emergencies. SGBV is everyone's problem, and we all have a responsibility and role to play in addressing this issue in the course of our work, regardless of what sector we are working in. Here is what you can do to help address SGBV during emergencies and disasters. 1. All our frontline staff and volunteers have a responsibility to apply the Do No Harm principle. 2. Staff and volunteers should get trained on SGBV and protection against sexual exploitation and abuse, core concepts, and be aware of the most up-to-date available local SGBV referral pathways. 3. Raise awareness among the communities about harmful effects of violence as well as healthy coping mechanisms to deal with stress, fear, grief, and trauma. Promote gender equality and available services to survivors. 4. Ensure that survivors are aware and have access to safe and appropriate survivor-centered SGBV services, including medical, psychosocial, legal, and shelter services. 5. Mainstream SGBV prevention and response measures into our preparedness and emergency response activities and programs from all sectors, including disaster risk reduction, WASH, shelter, livelihoods, health, and migration, including in our planning and budget processes. Make sure they are safe and do not put individuals at risk of SGBV. 6. Ensure coordination of efforts and services to respond to SGBV with existing local coordination mechanisms or working groups. 7. Independently of national legislation, no sexual relationships are allowed between humanitarian workers and affected people, nor may humanitarian workers purchase or exchange goods or favors for sexual services. These principles are part of the movement's adopted codes of conduct and protection from sexual exploitation and abuse policies. By taking our responsibilities to address SGBV, we can help stop this unacceptable form of violence. Working on SGBV can be emotionally overwhelming. Some staff and volunteers may have been exposed to SGBV themselves. It is therefore important to practice self-care and reach out to a trusted person if you need support. IFRC. Saving lives, changing minds.